Lesson 4.4, blood pressure. Equipment needed for checking blood pressure is a stethoscope, a sphygmomanometer, and a cuff. There are three measurements for checking blood pressure, or three methods. One is palpatory, two is oscillatory, and three is oscillometric. The palpatory method is the most commonly used, it's probably not actually the most common, probably the least common. This is where you're feeling the radial pulse, and we put an occlusive cuff on the arm and inflate it above the level at which the pulse became impalpable. So you're feeling it, you're pumping up the cuff, and then you no longer feel it. So that's when you can stop inflating the cuff. And then you're going to slowly and gradually deflate it while watching the manometer. And the level at which the pulse becomes palpable again is your systolic pressure. The oscillatory method is the most commonly used. This is where we apply the cuff 1 inch above the elbow crease, palpate the brachial artery, then place the stethoscope lightly over it, the chest piece. Inflate the cuff above the systolic level, which you could have determined already by the palpatory method, or you could also take an average of the patient's past readings, and then slowly lower the pressure in the cuff. And the level at which the carotid cuff sound is heard is the systolic pressure, and the level at which all sound disappears is the diastolic pressure. The oscillometric method is with the use of a sensor. So it uses the sphygmomanometer cuff, just like the oscillatory method, but then with the pressure sensor or transducer to observe oscillations in the cuff pressure. The pressure sensor within the inflated cuff detects the pulsation of the artery wall as a pressure vibration, and the interpretation of those small vibrations provide the blood pressure value. And typically it will give you the systolic, diastolic, and the pulse rate as well. The sphygmomanometer is the instrument used to measure blood pressure. Generally, we use an aneroid sphygmomanometer, which is a gauge with the scale calibrated in millimeters. The needle points to the calibrations, and the needle must always start at 0 before beginning taking the blood pressure. If the manometer is not correctly calibrated and the needle is not at 0, it's going to give you an abnormally high reading. It's going to be inaccurate. We have a variety of blood pressure cuff sizes, and the size of the cuff refers to actually the inner bladder that is inside the outer covering. So typically you have an outer covering, usually made of something like nylon that can easily be sanitized. And then there's a bladder inside, almost like a thick rubber balloon. So the inner bladder of the cuff should encircle 80% of the arm circumference, or wherever you're taking the blood pressure, but typically we use the upper arm. And it should be wide enough to cover 2/3 of distance from the axilla to the antecubital space, so the armpit to the crease. And the cuff must fit properly to get an accurate reading. If you have an improperly fitted cuff, the blood pressure reading will be inaccurate. So usually the cuffs will have measuring markers on them to ensure that it's fitting properly. So we usually have a child cuff used for children or very small adults with thin arms. There's an adult cuff, which is used for average size arm, and a large cuff used for adults or teens with larger than average sized arms. And then a thigh cuff used for thigh or adults with large arms. If the cuff is too small, the reading will be falsely high. If the cuff is too large, the reading will be falsely low. The cuff should fit snugly. Center should be directly over the brachial artery. So typically you'll find an arterial marker on the cuff, maybe with an arrow, and this should be placed directly on top of, above the, and pointing to the brachial artery, which you're going to palpate first so you know where it is. This way it allows complete compression of the artery, and then they usually have Velcro to secure the cuff. So again, remember, cuff is too small, your reading will be too high, will be falsely high. And if the cuff is too large, the reading will be falsely low. What is the blood pressure? This is the force exerted by the blood on the walls of the arteries. So systole is the phase when the heart contracts or tightens, and that's when blood is pushed out of the heart, which creates pressure on the artery walls. So the systolic pressure is the point of highest pressure on arterial walls. So this will always be our highest, our first number for blood pressure. Diastole is the phase when the heart relaxes in between contractions. So the diastolic pressure is the point of lowest pressure on arterial walls, and that's because the heart is relaxed. So blood pressure is usually abbreviated BP, and the measurement is expressed as a fraction. So the numerator, the top number, will be the systolic pressure, or the higher number. And the denominator will be, the bottom number will be the diastolic pressure, or the lower number. And it's measured in millimeters of mercury, which is abbreviated mm, and Hg is the elemental sign for mercury. So the guidelines currently are a normal blood pressure for an adult should be less than 120/80 millimeters of mercury. So notice that there is really no lower boundary, but we definitely have an upper boundary of 120/80. So pre-hypertension, hypertension is abnormally high blood pressure, would be anything from 120 to 139 systolic, and it could be and or anything 80 to 89 diastolic. So you could have one number be prehypertensive or both of them. And we take the BP pretty much at every office visit so that we can compare the readings over time, and it gives us a good index of a baseline BP. If it rises or falls of 20 to 30 millimeters of mercury, that would be significant for the patient, even if it's still in normal range. So if you could have a patient whose normal resting BP is, say, 90/60, and then if it all of a sudden jumps to 120/80, even though that's still in normal range, that could be a cause for concern or indicate something's going on with that patient. So hypertension, again, is high blood pressure or excessive pressure on the arterial walls. And hypotension is low blood pressure, so reduced pressure on arterial walls. Typically, it's below 95/60 would be considered hypotensive. Factors affecting blood pressure: age. As age increases, the blood pressure gradually increases because aging causes a loss of elasticity in the arterial walls, which causes an increase in pressure. So here's our average optimal blood pressures for age. Newborns, pretty low. 1 month old, 85/54. 1 year, 95/65. 6 years old, etc. And then eventually get up to adults, which should be 120/80 or below, less than. Gender. So after puberty, women tend to have a lower blood pressure than men of the same age. But then after menopause, women's blood pressure tends to be higher. So you can get variations throughout the course of the day. Typically, blood pressure is lower in the morning and then gets higher in the afternoon. Strong emotional states can increase blood pressure, such as anger, fear, and excitement. So, of course, we always want to try and have our patient be as calm as possible when we're checking their blood pressure. So, if your patient's really, really anxious or upset, it might not be the best time to take it. Exercise temporarily increases BP. If the patient's been involved in physical activity, you want to try and allow them to rest before taking their blood pressure. Usually takes about 20 to 30 minutes to normalize after working out for an extended period of time. If a patient just ran up the stairs to get to their appointment on time and rushed into the exam room, it shouldn't take 20 to 30 minutes, right? Hopefully by the time you finish checking them in, it'll have normalized. But if not, it's not unreasonable at all to wait to check the patient's blood pressure until even after the bulk of their visit with the provider. Blood pressure varies based on body position. So you're going to make a notation if the patient is in another position other than just sitting, which is the typical normal position we would want them in to check their blood pressure. And of course, medications can increase or decrease the blood pressure depending on the type. So it's always important to record any prescriptions and over-the-counter medications in the patient's chart. Other factors, pain will definitely increase the BP. Recently eating, smoking, and if their bladder is very full, that can raise the blood pressure. The Korotkoff sounds. So these are the sounds that determine the systolic and diastolic blood pressure readings when we're taking it using the oscillatory method. So when the bladder of the cuff is inflated, the brachial artery gets compressed. So no sounds should be heard through the stethoscope. As we deflate the cuff, always at a speed of 2 to 3 millimeters of mercury per second, you'll begin to hear sounds as the blood begins to flow freely. And then as it begins to flow freely, you should no longer hear sounds. So that very first sound will be our systolic. And when the sound can no longer be heard, when the blood is flowing freely, that is the diastolic. So we want to, this is ideal, right? Tell the patient not to consume any caffeine or tobacco for 30 minutes before checking their blood pressure. It's pretty hard to change that once they've already gotten into their visit with you, if they just had their cup of coffee or just consumed some tobacco. But as I mentioned before, you always want to have them seated in and kind of calm and quiet for at least 5 minutes before taking their blood pressure. So we do everything else first and kind of save that for last. And always use the proper cuff size. You don't want to take the blood pressure over clothing because it can interfere with the ability to hear the sounds and could result in an inaccurate blood pressure reading. So either roll up the patient's sleeve. A lot of times this will make it too tight though. If it's a tight-fitting long sleeve shirt, then this causes compression of the artery before you even get the cuff on. So like this patient has here, in that case, you would have the patient just slip their arm out of the sleeve. You want to have the arm positioned at heart level, and it should be well supported. So ideally on a table or a counter or something, or armrest. Palms should be facing upwards so that you can get into the antecubital space and find the brachial artery. If the arm is above heart level, then the blood pressure is going to be falsely low because it's has a hard time traveling up in the arteries of the arm. Remember, gravity, everything tends to flow better downward. You definitely want to avoid getting extra sounds from the cuff. A lot of times you'll get kind of scratchy noises or movement, or if the tubing is hitting your chest piece of the stethoscope, it will make it very hard to hear those Karate cough sounds. So extra sounds can interfere with your accurate measurement. You want to make sure you have 1 to 2 inches between the bottom of this cuff here and the antecubital space, the bend in the elbow. That way you're preventing the stethoscope from touching the cuff. If the cuff is or the tubing is touching the chest piece of the stethoscope, you'll hear it. You want to compress the brachial artery completely with the center of the cuff directly over the artery. As I said before, most cuffs have an arrow. Right here, this one says artery with an arrow pointing down. And notice here you also have a range, so you can see where the cuff should meet. And if it doesn't close within that range, then it's either too big or too small. As I said, avoid extra sounds from the tubing. So try and free it so it hangs freely and doesn't touch the stethoscope. You don't want it to rub against anything. You'll definitely hear the extraneous sounds, and it makes it very hard to hear the actual Karate cough sounds and get an accurate measurement. Very, very important that you release the pressure at a moderate, steady rate of 2 to 3 millimeters of mercury per second. So this takes a lot of practice in controlling whatever mechanism you have for pumping up the air and then releasing it. Because you want the needle to move down the sphygmomanometer at a rate of 2 to 3 millimeters per second. So that's a tick mark. Every single tick mark on there is 1 millimeter. If you release it too quickly or too slowly, you're going to miss the sounds and miss the reading that correlates with the sound or absence of sound. So you'll get a false reading. Avoid venous congestion, right? So if you have to take the blood pressure again, if you need to recheck it, and it has to be on the same arm, you want to make sure you wait at least, I would say 2 minutes. 1 is probably a little not long enough. This allows any blood still trapped in the veins to be released, because if we've already compressed them once, they get kind of trapped in there. So you could either, if you need to recheck it right away, try and use the other arm, right? Or wait the appropriate amount of time to recheck it in the same arm. Often in a new patient, you're going to want to measure and record the BP in both arms, because you're going to normally get a small difference or variance of 5 to 10 millimeters of mercury between the two arms. And then, of course, we're going to take the higher initial reading as our what we would consider as the blood pressure for the day. But oftentimes I will record it in both arms. You might get some with a much larger variance than 5 to 10 millimeters, and that's definitely something you want to alert the provider to. Basically, what that could indicate is that there's probably some sort of arterial blockage, affecting the reading in one of the arms. Okay, so that concludes lesson 4.4.